Over the years, I've gained so much from so many. Some amazing people in my life who have cared with boundless love. Eternally grateful I am to them. I'm also thankful to the teachers who have given without holding back. So, can I give something back? I certainly hope so. Hopefully, this will be helpful to some young physicians in their clinical journey and in their exam preparations. That for me would be amazing. Hello everyone, welcome. Today's presentation is by a physician's cup of coffee, and it's on the significance of urinary pH in NAGMA related pathologies. Understanding the urinary acidification and the urinary pH is an important tool in terms of assessing renal tubular acidosis, the different types and the differentials of NAGMA pathologies. Along with urinary anion gap and urinary osmolar gap, the urinary pH would very much help in the differential diagnosis. The appropriate renal response to a metabolic acidemia is to excrete the acid. Excreting acid is done by generating excessive hydrogen ions, which then combine with the ammonia to form ammonium. This process of ammonogenesis uses up hydrogen ions. However, there are free hydrogen ions still left to keep the urine pH less than 5.5. Thus, in summary, in a metabolic acidosis, when there is an appropriate response by the kidney, you expect the urine pH to be less than 5.5. There are two types of distal RTAs, type 1 and type 4. Type 1 is a defect of alpha intercalated cells not secreting hydrogen ions. Thus, a distal type 1 RTA would persistently have a urine pH higher than 5.5 because the primary defect is in distal acidification. There is a defect in hydrogen ion secretion. Thus, the urine pH is on the higher side. So, we could go to the extent of saying that if you do have a urine pH that's less than 5.5, that excludes distal type 1 RTA. Now let's look at the urine pH in the major NAGMA differentials. That is, in the three types of renal tubular acidosis and the non-RTA major pathology, chronic metabolic acidosis created by chronic diarrhea. Let's look at the urine pH in all of these conditions. As we discussed in the previous slide, the appropriate renal response to acute chronic metabolic acidosis with acidemia is to secrete hydrogen ions and reduce the urine pH to less than 5.3. There would be ammonogenesis, there would be using up of hydrogen ion, but there would be enough hydrogen ion secreted to keep the urine pH less than 5.3. That is normal physiology. As we discussed previously, in distal type 1 RTA, despite acidemia, you have a urine pH above 5.5. This is due to a defect in hydrogen ion secretion by the alpha intercalated cells. You don't have hydrogen ions, thus your pH is on the higher side. The next pathology is the other distal RTA, which is type 4, where the pathology is at the principal cell. Here the principal cells don't secrete hydrogen ion, but the alpha intercalated cells maintain hydrogen ion secretion. So here, when you have a defect in hydrogen ion secretion, the pH is still unduly on the lower side, which is maintained below 5.5 despite impaired hydrogen ion secretion. The reason for that, one is the hyperkalemia related to the distal renal tubular acidosis results in a defective ammonia genesis. In fact, the way I should say it is hyperkalemia leads to a defective ammonia genesis. Thus, the low ammonia available to bind with hydrogen ions leaves quite a significant number of hydrogen ions free to acidify the urine. So thus, even though you have a defect in principal cells secreting less hydrogen ion, you have a urine with a pH of less than 5.5. The third type of RTA being the type 2 proximal RTA, where the defect is in the proximal convoluted tubule. Here you have a defect of reabsorbing or reclaiming the filtered bicarbonate. So you have bicarbonate being wasted in the urine. You would expect the urine to be alkali, pH above 5.5. However, here too you would very commonly find that the urine pH is less than 5.3. The reason for that is when the body has lost a significant amount of bicarbonate, the amount of bicarbonate filtered comes down. So you have a low number of bicarbonate being filtered, and that bicarbonate, the body is able to reclaim the low number of bicarbonate, thereby freeing the urine from bicarbonate. Also, to keep in mind is that the distal segments are intact and they are able to generate and secrete hydrogen ion, thereby acidifying the urine. So despite having a proximal defect where bicarbonate is being leaked into the urine, you still will most commonly have a urine pH on the lower side. Thus, among the three renal tubular acidosis, it's only the distal type 1 RTA that consistently has a urine pH above 5.5. Going on to the non-renal pathologies of NAGMA, that is chronic diarrhea. Here you would have a chronic metabolic acidosis because bicarbonate being lost in diarrhea, and you would expect having an acidotic state for the appropriate response being kidneys losing acid, the acid component, and thereby acidifying the urine to have a lower urinary pH. However, you would find that in chronic diarrhea, despite the kidneys appropriately excreting the acid in the form of ammonia, that leads to the increased ammonia genesis, leads to the hydrogen ions being used up. There would be excessive ammonia genesis and the hydrogen ions would be used up, and then you would have less number of or no hydrogen ions in the urine, thereby you would have a pH that is on the higher side. Here, although you have acidemia and the kidneys are intact and appropriately excrete the acid in the form of ammonia genesis, due to the increased ammonia genesis, you have increased usage of the hydrogen ions, and then you have a urine that without hydrogen ions being with a higher pH. Thus, in distal type 1 RTA and chronic diarrhea, you have a urine pH on the higher side, which is inappropriate for the clinical situation. I would like to explore the RTA type 4 a little bit further. RTA type 4 is a defect in the principal cell, that is hypoaldosteronism, and a defect in the principal cell of secreting hydrogen ions into the urinary lumen. So it is not unreasonable to think that a defect where hydrogen ion secretion is impaired, the urine pH to be on the higher side. However, it's very common to find that you have a urine pH less than 5.5 on the acidic side in a RTA type 4. How does this happen? Okay, for that we need to understand that apart from hypoaldosteronism related hyperkalemia and metabolic acidosis, there is a primary defect of decreased urinary ammonium excretion. This is the major reason that you have a urinary pH on the lower side in RTA type 4. How does that happen, and how does this cause a lower urinary pH? Okay, it's important to understand that although there is a principal cell defect in secreting hydrogen ions, the alpha intercalated cells are intact and they continue to generate and secrete hydrogen ions. So although the type 4 RTA has a lesser number of hydrogen ions being generated and secreted, it is still available to acidify the urine to a pH less than 5.5. Now in such a situation you also have defective ammonium excretion. So you have defective ammonium excretion, ammonia not coming into the urine to combine with the hydrogen ion and form ammonium. So the hydrogen ions, although a small number that is being secreted, they are still left free to acidify the urine. If we understood that concept, then we would understand that it is not unreasonable now to say that the urine pH would be on the lower side in RTA type 4. The next thing for us to understand or know that there is, like I said, decreased urinary ammonium excretion, and how does that actually happen? Three mechanisms, quite a few mechanisms have been proposed for the decreased ammonium excretion in type 4 RTA. But it's important to remember there is decreased urinary ammonium excretion, leaving the small number of hydrogen ion free to acidify the urine for a pH less than 5.5. The mechanisms proposed for a decreased ammonium excretion are, the most important one is you've got hypoaldosteronism related hyperkalemia. So with hyperkalemia you have potassium entering the cells, and to balance electroneutrality the hydrogen ions exiting the cells. So you create thus you have a situation where you've got intracellular alkalosis and the kidneys trying to respond appropriately by conserving the acid in the body, thereby decreasing the ammoniogenesis and decreasing the excretion of acid to neutralize the intracellular alkali environment. That's the primary mechanism of decreased urinary ammonium excretion. The other mechanisms are ammonium and potassium compete for the same channels and the same transporters in the cell membranes. When there is hyperkalemia actually overpowers the ammonia in occupying these membranes and prevents the ammonia from being recycled from the interstitium into the urinary lumen. Thereby hyperkalemia prevents the excretion of ammonia in that manner as well. So you have less number of hydrogen ions being secreted, but you have a decrease in urinary ammonium excretion which don't utilize those hydrogen ions by allowing them to reduce the urinary pH to less than 5.5. That's how you get a urinary pH of less than 5.5 in renal tubular acidosis type 4. So if you do remember that it's a defect in urinary ammonium excretion, then we could understand that that could have a pH on the lower side, even though there is a defect in the principal cells secreting hydrogen ions. Exploring the higher urinary pH in some of the NAGMA pathologies that we've already discussed, and looking at the actually underlying pathogenesis. The distal type 1 RTA and chronic diarrhea related NAGMA and later stages of toluene toxicity, which also will result in NAGMA, all have all are acidemic states but have inappropriately higher urine pH. But the mechanisms that lead to this are different. Let's look at how this happens. Okay. In distal type 1 RTA, the defect is hydrogen ion secretion at the alpha intercalated cells of the collecting ducts. Thereby, there is defective ammoniogenesis, and this is the cause leading to a higher pH. Whereas in the other two, it's a diametrically opposed different process. The kidneys are intact and they appropriately excrete acid product by excessive ammoniogenesis, thereby using up all the hydrogen ions and leading on to a higher pH, because there is no hydrogen ions left to acidify the urine. The hypokalemia associated with the diarrhea also promotes excessive ammoniogenesis. When we discuss hyper and hypokalemia and ammoniogenesis in renal physiology, we would look at this in more detail, but for now I think if you understand this is sufficient for us to get a better idea. So there are two diametrically different processes leading on to the same result of inappropriately higher urine pH in these conditions, that is type 1 RTA versus chronic diarrhea and later stages of toluene toxicity related NAGMA. We have looked at normal anion gap related metabolic acidosis that results in inappropriately higher urinary pH. Renal tubular acidosis type 1 was one. Chronic metabolic acidosis due to any cause, in this context due to chronic diarrhea causing a higher urinary pH. We've looked at the mechanisms. They are different, but both result in inappropriately higher urinary pH, and so does toluene related NAGMA. The other clinical situation that results in a higher urinary pH is urinary tract infection secondary to urea splitting organisms. That's something to be kept in mind, and if you have a higher urinary pH and you're investigating and find a higher urinary pH, always to be kept in mind, and doing a urine analysis and a urinary culture if indicated is something to be considered. Severe volume depletion is another situation where you could have a inappropriately higher urinary pH. The mechanism here is reduced distal sodium delivery, thereby there is no sufficient voltage generated for the sodium to be absorbed and potassium and hydrogen ions to be secreted into the lumen. So you don't have enough sodium to generate a voltage, and you don't have enough sodium for the principal cell to actively reabsorb sodium and excrete hydrogen ion and the potassium into the lumen. Thus, it's important to check for the urinary sodium levels before we make a assessment for the cause of reduced acid excretion or higher urinary pH. And this concept of reduced distal sodium delivery is an important concept in terms of assessing hyperkalemia related etiologies. There are very well documented clinical scenarios in literature where the reduced distal sodium delivery has been the cause of hyperkalemia. When we do discuss hyperkalemia related physiology, I actually plan to demo or present one of the cases that has been well documented in literature. So reduced distal sodium delivery as a cause of higher urinary pH, and more importantly as a cause of hyperkalemia, is something that is to be kept in mind. Eternally grateful to the love shown and sacrifices made by some amazing people in my life. I'm eternally grateful. Thank you so much. Did you find this presentation beneficial? If you did so, and if you liked it, kindly hit the like button and subscribe. These are some of the topics I plan to present in coming days, in particular the osmolar gap and approach to renal tubular acidosis in a detailed manner, and the other renal channelopathies. If you do have any particular topic that you would like to be covered, kindly let me know. Thank you very much for your time. Thank you for listening. See you another day.